In Uganda, healthcare and money are both in short supply, and a bill for treatment of a single serious illness often leads to a family's financial crisis. But this is a story about how communities are organizing to receive quality healthcare and protect families from the economic hardships of catastrophic medical bills. It's a story about how two different families dealt with their healthcare challenges. Farmer Richard Namara and his wife Connie grow crops among the tea plantations in the western Bushenyi district.
I used to fall sick myself, and my wife was sick often. It was a challenge because the bills were high and we wouldn't have the money to pay. I would start borrowing.
But Connie admitted that borrowing was very difficult because their neighbors, their friends, their family didn't have much money either. Meanwhile, in the northern Oyam district, where malaria and poverty are both endemic, Moses Okello and his family all came down with malaria within a single week.
It started with the curfew. Then the brother, Marcia in the morning, sister in the afternoon. I again took the mother 2 days later.
The family recovered, but
I was supposed maybe to sell my chicken or my goat in order to meet the medical bill.
1 in 7 Ugandans faces a similar situation every year, saddled with catastrophic medical bills. Many borrow or sell important assets. Others just delay treatment.
We have a sizable number of people who could not manage their health costs, and we've lost them.
All this despite an officially cost-free government alternative.
There's a government facility, but the quality of care is quite low, and it could as well be delayed. There is quality care at a private health facility, but the problem is that it's very costly and many can't afford it. The question remains, how can a small income earner access quality care? And the answer is through a health cooperative.
I was supposed to waste like 300,000 shillings. But because we already paid insurance, it costed us less than 50,000.
And that is why some 33,000 Ugandans have joined their local, member-owned and operated health cooperatives. It's why Moses' chickens and goats are still in residence. It's why Richard and Connie eventually joined a cooperative just in time. They now have 3 healthy children, all born by cesarean section, and they have no medical debt.
From the time we joined the group, our situation has become better. When you fall sick, you just go to the hospital and seek care, yet you've paid little money.
But none of this would exist without the efforts of a nonprofit called Health Partners.
We brought this idea to Uganda.
Over 2 decades, Health Partners has been in Uganda working with the key stakeholders.
A health cooperative is built on a risk-sharing concept where many people come together, pool resources.
It is the people who actually form the cooperative, who own it, who actually put together the resources.
Under this cooperative model, members prepay their health insurance premiums. That accumulated cash gives the cooperative and its members the financial leverage to negotiate a partnership with a local health facility, a clinic, or a hospital.
Healthcare providers sign a memorandum of understanding detailing the roles and responsibilities, the benefits that the members are going to get, and then they start accessing the care they need.
When patients come, they get care. They're attended to very fast, and to reduce on the waiting time, the turnaround time.
Somebody tells you, when my children fall sick, I don't have to wait.
We are also going out to do outreaches.
We encourage health education so that the care provider does not spend more of the money that has been prepaid to them.
We have to teach them how to prevent themselves from getting malaria, but also diseases of hygiene, hand washing, cleaning clothes, personal hygiene, and all that.
We have seen people fall sick less often.
The constant ill health we had has reduced. We can go a whole year without falling sick.
Under this arrangement, providers receive predictable advance payments as a lump sum, and they're now able to purchase adequate drug supplies in bulk, to budget for new equipment and improve facilities. They don't have to chase delinquent patients for payment. So there is growing interest among new healthcare providers, also from community groups, government ministries, and non-health cooperatives that would like to add a health component to their services. So Health Partners is in the field. They're informing stakeholders like these community leaders about the benefits and the challenges. They're working with startups to deal with licensing and governance, and they're successfully extending leadership capacity to underserved groups.
For example, women. A health cooperative provides opportunity for women to actually take up leadership.
I'm Marian Amanya. I am the board chair, Uganda Health Cooperative.
And that is something which is very critical in terms of social development.
Of course, it is challenging, and I don't mind about the challenges because it's through challenges that our cooperative has to grow, and myself, I have to grow as a leader.
As the board chair, Amelia can see many improvements as her cooperative grows. Among them, the intangible benefits that come with cooperation and cohesiveness.
When you go to the same healthcare provider, you even create a relationship.
We know which family has problems.
People know, even they can call your name. Hey, you are here.
Someone will just come, today I've not come for treatment. I've brought for you a bunch of matoke, right, which is a food stuff. Yes. Yeah.
Even you feel, you start healing before you are treated.
The key here is that the members, after paying, they are in control. A lot has changed about them. They are healthier, they are able to save money, they are more productive. Each and every person should want to have this kind of power to determine the kind of health services that they get. In the local language here, we say, amagara maronji twetambire, like, for good health, let's treat ourselves.